A 22-year-old female who is a known case of GAD. GAD stands for generalized anxiety disorder. Presents to the emergency room with complaints of sudden onset apprehension. Apprehension is an anxiety symptom, and uncomfortable feeling of impending doom. The preferred drug for the patient is. Now the answer here is alprazolam. Why so? This patient presented to us with psychological anxiety symptoms, and it's an acute exacerbation. Psychological anxiety symptoms are caused due to decrease in the levels of GABA. So we have to give a GABAergic drug. Propranolol is preferred in physical anxiety symptom, where we have palpitation, etc. when the norepinephrine levels are increased. Paroxetine is the drug of choice for GAD because SSRI are the drug of choice. But since the patient presents to you in emergency, the first drug here would be alprazolam. Please remember these key points. In emergency room, the drug of choice for apprehension is always benzodiazepine to manage the symptoms, and alprazolam is a good drug to manage acute anxiety symptoms. We can use etizolam, we can use alprazolam, we can use clonazepam, or we can use lorazepam. These are the commonly used drugs for acute anxiety management: lorazepam, alprazolam, clonazepam, and etizolam, LACE. Alright, but the overall drug to manage is SSRI. In GAD, usually we prefer sertraline, paroxetine, escitalopram, etc. Alright, this is about the first question. Next question. A 40-year-old female was brought to the mortuary after the death by deliberate self-harm, secondary to depressive illness. So depression, self-harm, death. So CSF examination will reveal. So we are dealing with a case of suicide. Self-harm leading to death is suicide, and suicide is linked to which neurotransmitter? Serotonin. Suicide is linked to which neurotransmitter? Serotonin. Please remember, suicide is linked to decreased serotonin level, and it has been biochemically proven by decrease in the level of 5-HIAA in the CSF. Decrease in the level of 5-HIAA, this is all India PG repeat question. 5-hydroxy indole acetic acid. 5-hydroxy indole acetic acid. That's all about the second question. Number 3. A 65-year-old male who is known case of MDD. MDD stands for major depressive disorder. Was on capsule fluoxetine 20 mg. Was brought to the OPD with bradykinesia, rigidity, and resting tremors. Bradykinesia, rigidity, resting tremors are symptoms suggestive of Parkinson. Now he was given selegiline. Now the problem is selegiline itself is a MAO inhibitor. So MAO inhibitor increase the serotonin levels, and your SSRI also increase the serotonin level. So when you give a two pro-serotonergic drugs together, then you are supposed to worry for a dreadful syndrome called serotonin syndrome. Let me make it clear. Serotonin syndrome is caused by pro-serotonergic drugs. Now pro-serotonergic drug can be an SSRI, can be a MAO inhibitor, can be an SNRI, or can be a TCA. Now when you are combining the two, the risk of having serotonin syndrome increases. Serotonin syndrome is caused by pro-serotonergic drug. SSRI, MAO inhibitor, then your SNRI, even TCA are known to cause serotonin syndrome. Please remember these key points about serotonin syndrome. Clinically, it manifests as anxiety, agitated delirium, restlessness, and disorientation. These are the mental status changes. Autonomic manifestation include diaphoresis, tachycardia, hypothermia, vomiting, and diarrhea. Sometimes diarrhea is the first manifestation, just similar to carcinoid syndrome, and it is a part of drug-induced fever syndrome. Drug-induced fever syndrome also includes your NMS, serotonin syndrome, malignant hyperthermia. This is not a part of psychiatry, but these two are. So it's a drug-induced fever syndrome. Then neuromuscular hyperactivity manifests as tremor, muscle rigidity, myoclonus. Clonus is a very important sign of your serotonin syndrome. Hyperreflexia, and these findings are more in the lower extremities. Okay, these findings. This flushing, hyperreflexia, myoclonus, and shivering. These differentiate serotonin syndrome from neuroleptic malignant syndrome, which is caused by anti-dopaminergic drug like antipsychotics. So if they ask you the difference between SS and NMS, SS has flushing, hyperreflexia, myoclonus, and shivering. I repeat, flushing, hyperreflexia, myoclonus, and shivering, which is not present in NMS. Okay. Next question. A 25-year-old male was brought to the emergency room with aggressive behavior, disinhibition, and irritability after a traumatic brain injury, TBI sequelae. The likely lobe injured. Now the patient presents with disinhibition, irritability, aggression. So the part of the brain affected is frontal lobe. Why? Because the functions of the frontal lobe are personality, emotion, and social behavior. So frontal lobe keeps you inhibited, socially well behaved. So loss of frontal lobe function is your frontal lobe dysfunction, is your disinhibition, over-familiarity, over-talkativeness, lack of initiative, antisocial behavior, and impaired memory. The frontal lobe dysfunction syndrome has been asked many times. Please, if you don't have notes of this topic, note these points. Changes after frontal lobe lesion. Number 1, over-familiarity, over-talkativeness, prankish joking and punning. Then lack of social control, especially sexual disinhibition. There was a case, Finn's gauge. A rod was inserted in his head, rod was removed, after which the personality and the behavior in him was observed to be changed. So which part of the brain is damaged? Frontal lobe. Gross error of judgment, lack of insight, diminished anxiety and concern for the future, lack of initiative or spontaneity, profound psychomotor slowing, sometime amounting to stupor. So they can ask you, stupor is seen in which part of that? It is specifically seen in anterior cingulate cortex injury, which is a part of prefrontal cortex, which is eventually a part of the frontal lobe. Inability to plan and follow. So these are the through a course of action changes. When we are doing frontal lobe, let's make a list of other lobe functions as well. So how will you solve these type of questions? TBI sequelae. Just remember the function of the lobe and reverse it. Those are the symptoms seen in the lesion of that. For example, parietal lobe. What are the function of the dominant side? Calculation, language, planned movement, appreciation of size, shape, weight, and texture. So if parietal lobe dominant side is affected, you will have dyscalculia, dysphagia, calculation, dyscalculia, language, dysphagia, planned movement, dyslexia, apraxia, motor problems, agnosia, sensory recognition. Are you understanding? The concept is, if you know the function, you can find out the lesion. But they will not give you like this. They will give you the symptoms. Now you are supposed to tell which part of the brain is damaged by correlating the function of the lesion. This is called as functional neuroanatomy correlation. Okay, non-dominant side, I hope you might have heard of this. Neglect, hemi-neglect, spatial orientation and construction. These are all neurological, signs. Then again, dressing apraxia and homonymous hemianopia. This is just a list for your reference. Temporal lobe, dominant side, auditory perception, speech and language, verbal, memory and smell. So dysphagia, dyslexia. Memory is an important function of temporal lobe. In complex hallucination in two modality, homonymous hemianopia. Non-dominant side, auditory perception, music, tone sequence. If you're not able to note these points in my rhythm, you can pause and take a note of it. Poor non-verbal memory, these notes are important, okay? And loss of musical skill, complex hallucination, homonymous. Then occipital lobe, I don't have right and left. Homonymous hemianopia, hemianopic scotomas. I don't think so I'm the right person to explain you all these terms. These are neurological terms. Some of them are your ophthalmology terms. You might be aware about visual association area and primary visual cortex. Okay, in occipital lobe. That's all about this question. Next question. A 37-year-old female presented to the OPD with complaints of sensation of current passing through her body, which is controlled by her neighbors, through a chip inserted in her brain and heart since 4 years. Okay, so the daughter reports of patient talking to self and gesticulating. Probably I am dealing with a case of none other than schizophrenia. Current passing through the body, so I am dealing with a symptom of passivity. And passivity is a type of a delusion only, false belief, and delusion means a positive symptom, and positive symptom are linked to increased dopamine in the mesolimbic pathway. In order to solve this type of question, you need to know the dopamine pathways. So there are 4 dopamine pathways which you need to remember: mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular. and positive symptoms are related to increase of dopamine in the mesolimbic pathway. All your delusions and all your hallucinations. Your negative symptoms are related to decrease of dopamine in the mesocortical pathway. Your movement side effects, that is antipsychotic induced EPS, are linked to nigrostriatal pathway, and increase in prolactin level due to antipsychotic is linked to tuberoinfundibular pathway. You can even note the localization. I will try to highlight them. Have a look at this. This starts from the ventral tegmental area and goes to the cortex. This is your mesocortical pathway. Then kindly have a look at this. It starts from the hypothalamus, goes to the pituitary. This is your tuberoinfundibular pathway. Then this starts from the substantia nigra and goes to the striatum. This is your nigrostriatal pathway. And the fourth, which is the answer of our question, is your mesolimbic pathway. Mesolimbic is from your ventral tegmental area of the midbrain to the nucleus accumbens. Mesocortical is from the ventral tegmental area of the midbrain to the dorsolateral and the ventromedial prefrontal cortices. Then tuberoinfundibular is from the hypothalamus to the pituitary, and nigrostriatal is from substantia nigra to striatum. A 20-year-old male who is having 60% intellectual disability is brought to the OPD with talking to self, gesticulating and suspiciousness in 7 months. First of all, you need to know that it is a case of intellectual disability plus schizophrenic symptoms. So intellectual disability is there plus schizophrenic symptoms are there. So this is a case of prof schizophrenia. Okay. So when we have schizophrenia plus mental retardation, we call it as prof schizophrenia. First F is silent. You need to know about different types of schizophrenia. One is prof, mental retardation plus schizophrenia. One is pseudoneurotic. Initially there is a predominant neurotic symptom, later shows a picture of schizophrenia. Oniroid, waking dream, acute onset clouding of consciousness, dream-like state, and deficit schizophrenia, only negative symptom. You can add on this von Berg, that is self-mutilation seen in schizophrenia. Self-mutilation seen in schizophrenia. A 30-year-old male was brought by his 3-month pregnant wife to the medicine OPD with a complaint of abdominal pain, craving for food, nausea, vomiting, weight gain and generalized aches. All investigations are normal. Did you see that it's not the male who is bringing the pregnant wife, it is the pregnant wife who is bringing the male. And the husband is having abdominal pain, food craving and morning sickness, what do you call it, nausea, vomiting. This is a case of Couvade syndrome. Too much emotional males have it. It is expectant father experience somatic symptom during the pregnancy for which there is no recognized psychological basis. There are symptoms of pregnancy like nausea, morning sickness and often a toothache, and occurs commonly in the 3rd month of pregnancy. Okay, generally resolves after a few weeks. Very rarely seen in India because it is too much over-involved emotional husbands, which are not found in our country very much, according to my experience. So Couvade syndrome is husband having pregnancy-like symptoms when the wife is pregnant. Okay, Couvade syndrome. I guess you know about the other option. Declarambot is the delusion of love, erotomania, where a lower believes that lower socioeconomic status believes that a higher socioeconomic status is in love. Cotard is delusion of nihilism, and Capgras is a delusion of doubles. Okay. Last question of the sequence. A 25-year-old male was diagnosed to have BPAD in mania, bipolar affective disorder in mania, and was prescribed one tablet lithium 450 mg twice daily, one in the morning, one in the evening. After how many days will you check for serum lithium level? Now, answer is 5th day. because the pharmacokinetic of lithium says that when we give oral 99% bioavailability and T half is 1 day. So the steady state is achieved after 5 days. The steady state is achieved after 5 days. So we start monitoring after 5 days, that is on the 6th day. So if they ask you on which day you will monitor, then answer is 6th day. And if they ask you after how many days, then after 5 days. Okay, 6th day. Okay, so 5 days it requires to achieve the steady state concentration. So then we do the testing on the 6th day. And when we do testing, the patient must have not taken the morning dose. We collect the sample for the serum lithium levels early morning, not empty stomach, but the patient must have taken the previous evening dose. For example, 8 AM, 8 PM are his 2 dosing time. So 8 PM he must have taken dose, and he must have been off medication, means not taken the morning dose. So we are not going to skip any dose for collecting serum lithium. I repeat, serum lithium levels are to be collected morning sample. Postponing morning dose. So first he will give the blood sample and then take the morning dose. Okay, but the doses need not to be altered, and you must be knowing 0.6 to 1.2 milli equivalent per liter is the therapeutic level of lithium. So it is excreted in the urine, and we want a basic therapeutic level, like for maintenance 0.6 to 0.8, and for acute mania 0.8 to 1.8.